Good evening, everyone. Tonight is going to be like a light night, just not like me. I usually put a lot of slides with a lot of data and graphs and all that stuff. Today is going to be straight to the point.
We're happy with that.
I think that would be the best. So enjoy your night, enjoy your dinner, and all you need to do is just to listen to me and believe me, trust me. Okay, so moving to the next slide. Okay. So Mace, I think, talked about managing AF patients and about the anticoagulation and Xarelto. So the slide here is anticoagulation in atrial fibrillation patients. We all know that there's a certain indication for AF, but what I'm trying to say here that if you have a patient with renal impairment, severe pre-dialysis, not on dialysis, the creatinine clearance is still above 15, still between 15 to 25, you're still able to prescribe NOAC. And the NOAC I'm talking about that's TGA approved is rivaroxaban, Xarelto. So not necessarily you move those patients to warfarin, you're still able to give them Xarelto down to 15 mils per minute. Below 15, when it's become severe or patient needs dialysis, you have to move to warfarin. You don't have any other option. Next slide, talking about antiplatelets and anticoagulation in patients with PCI. So up to recently, we didn't know what to do, but the European guideline did publish a paper, and they gave us a guideline as how to treat patients need to be on anticoagulation. So for those come to hospital with acute coronary syndrome, on anticoagulation, you keep them on anticoagulation throughout the procedure. NOAC should continue throughout. The clopidogrel continue for a minimum of 6 months if they are at bleeding risk. If they're not, we continue for 1 year. After 1 year, you stop all antiplatelets and they continue on anticoagulation only. That's for the ACS patients. For the elective PCI, again, they continue on NOAC. You add clopidogrel into the mix, you add aspirin. You stop the aspirin after 1 month, continue on a clopidogrel for a minimum of 6 months. You can continue for 12 months. After 12 months, you stop all antiplatelets and stay on NOAC only. So this is a guideline from the European Society of Cardiology, and basically that's our current practice. I usually put them on 3 agents, aspirin, clopidogrel, and continue on NOAC for first month, stop aspirin afterwards, continue for 1 year if possible, or stop the clopidogrel if they are at higher risk of bleeding at 6 months and continue on NOAC and after. So this is basically with the new generation drug-eluting stents that's included in here. So this is not a bare metal stent, this is a drug-eluting stent, and we still do that. Next slide is anticoagulation cessation before surgical procedure. Now, we're talking here about surgical procedure. It depends on low risk or high risk surgical procedure. For low risk surgical procedure, 24 hours should be enough. For high risk surgical procedure, probably you need about 48 hours or more. So anticoagulation to stop before surgical procedure. Now, for coronary angiogram, and that will be probably our protocol from now on at the Austin, anticoagulation will continue throughout the procedure. But again, it depends on the operator. If he's confident to do so, or want to stop anticoagulation 24 to 48 hours beforehand. There is a risk by stopping the anticoagulation before surgical procedures. There's a risk of stroke, and that's why we're trying to avoid that. We believe with the radial procedures now, most of our angiograms, we do them radially. The risk of bleeding is small. That's why we believe if we continue with anticoagulation throughout the procedure, the risk of bleeding is very small and the risk of stroke should be kept low. So that hopefully will be our new protocol at the Austin, but again, it still depends on the operator.
Sorry, Ali, can I just ask?
Sure.
That low risk procedures, does that include dermatological procedures or not?
Well, it depends. If you think dermatology procedure is a low-risk procedure, so then yes, it is. So anything you can control bleeding, considered low risk. But we're talking about, for example, vascular procedures, major procedures under general anesthetic, that's major procedure. So anticoagulation to be stopped 48 hours beforehand. And keep in mind, you can see on the left-hand side of the slide, creatinine clearance. So in patients with renal impairment, you probably need to consider, even with low-risk procedure, to stop the anticoagulation 48 hours beforehand.
You give heparin,
If you continue NOAC during the PCI procedure, you mean? For angiogram, for radial procedures, I would. Matthias?
Yeah, but there's no data,
Yeah.
Maximum.
Well, for the radial procedures, we give small dose of heparin. It's about 5,000, 4,000, 5,000 units of heparin during the radial procedure. For PCI, we give higher than that. We give probably, but generally speaking, even those patients on anticoagulation, probably just to feel more comfortable, give them heparin. The next slide is heart failure management. I see a lot of patients, they coming to me and they either they're not on anti-heart failure therapy, or if we put them on beta blockers, they're still on the same beta blockers dose I put this patient on 6 months ago. So no up titration of beta blockers, no new medication started. Despite that, all these medications now, general practitioners can prescribe, but we can see that probably either GRIPs are not doing their job right, or maybe we are not doing our job right. So to start with the Forxiga or dapagliflozin, we know it's a diabetic medication, but now it's been approved to treat patients with heart failure, regardless whether they are diabetic or not. So as I said, the slides today is not with data or graphs, just to let you know, you can go and search that. The other drug which I've been using for a while now, it's been available in the market for a while, and again, I see that most of the general practitioners not keen, but they either worried or they send the patient to the cardiologist before they start on the Entresto. And we know that sacubitril and valsartan is a very good in terms of drug as an anti-failure therapy, and every patient with ejection fraction less than 40 and they're symptomatic with the New York Heart Association class 2, 3, they should be on Entresto on top of other medication. Of course, there's a switch from the ACE inhibitor to the Entresto or from the A2RB to Entresto. I'm not going to talk about this. I talked about this before. Hopefully everyone knows that. The ivabradine, the other drug, if patient on maximum dose of beta blockers, maximum tolerated dose of beta blockers, and they're still running a heart rate above 70, ivabradine is available. And it is indicated for these conditions in particular. The patient in sinus rhythm, on maximum tolerated dose of beta blockers, heart rate is still above 70. Ivabradine is an option, and we should actually consider that as one of the anti-heart failure medication. The AF ablation, again, we had a paper presented recently about the AF ablation. So patient with heart failure in AF, difficult to control with beta blockers or other agents, consider AF ablation. So that also can be a treatment. In some patients, not just AF ablation. If they run a fast heartbeats and you can't control them with beta blockers or other agents, even like an AV node ablation and pacing, that also can be considered. Again, it's not a decision, I'm not expecting that sort of decisions you take, but those options are available just to make you aware of. Biventricular pacing, there's a certain indication, like a left bundle branch block is the main indication with ejection fraction probably 35 or 40% or low. On maximum therapy, you also need to think about biventricular pacing. What else? Iron infusion. Again, that's for you guys. Iron infusion, there's a certain indication in patients with heart failure. You need to probably do an iron study from time to time and consider iron infusion, which improve patients' overall health and reduce hospitalization. So that's something to consider as well. Ischemic heart disease and hypercholesterolemia. Again, just to make you aware of that there are more than statin available. I know we all talk about fenofibrate, statin therapy, ezetimibe. These are the main agents we use. Absolutely, there's no doubt. I'm not saying that every patient should be on evolocumab. What I'm saying is there are some certain number of patients who are either intolerant to statin or they are on maximum dose of statin and still the LDL not on the target. What target LDL should be less than 1.8 for secondary prevention? Well, I think the lower the better.
What's the PBS indication for this one?
For evolocumab? Well, familial hypercholesterolemia, that's one of them.
How can you prove it?
You can have a genetic testing if you want to.
How much it costs?
You can ask.
$2,000-3,000?
Well, that's if you want to do that.
Yeah, but now they said it's indicated for non-familial.
Yep, that's the second one. So the second indication for non-familial. So,
Can GP prescribe this one? Or non-familial?
they can. I think you need to have a specialist approval for that. You need to have the initial prescription need to be approved by the specialist. So the specialist can be an endocrinologist, hepatologist, and I think a cardiologist as well. So general med and cardiologists need to approve the initial prescription, and then the GP can continue with that. So yes, the second indication for that for the PPS for non-familial, young age with ischemic heart disease, intolerant to statin therapy, or not achieving target of LDL below 2.5. Although 2.5 we don't think is a target for secondary prevention, but that's what's available for us at the moment. The lower the better, LDL, so not, when you talk about LDL less than 1.8, yes, but the lower the better. If you're able to drive the LDL as down as 0, go for it. Do it if you can. I know it's hard, it's difficult. So that's the evolocumab, and again, as I said, I'm not going to talk about details about the evolocumab and how it works, but it works. Now, next one. I see a lot of patients coming to me with a calcium score requested by, again, general practitioners. Calcium score you need to pay for. So if you send patient for calcium score only, you need to pay for. So the patient will pay for it. It's not covered. But is it enough? I think you need to think about when you send patient for calcium score. Is it enough? Well, I'm just going to give you an example. This is one of my patients, 50 years old man, class 3 angina, New York Heart Association class 2 dyspnea, over 12 months, ongoing shortness of breath, getting angina, chest pain. He's a smoker, has family history of ischemic heart disease. His brother died at the age of 50, calcium score of 0. So if you put this calcium score of 0 into any calculator, it will give you a low risk of cardiovascular event. He's 50, young, yes, he's got some other risk factors, but with calcium score of 0. So what do we think? Well, yeah, need an angiogram. Okay, so this patient has a CT coronary angiogram. And for those, we have some imaging doctors here. Clearly, we can comment on the CT coronary angiogram. It's advanced coronary artery disease with no calcium. So this patient has a calcium score of 0. He's 50, has a significant coronary artery disease with no calcium. So what's the point? Why are you sending patients for calcium score if you can, with extra 10 minutes, inject some contrast and get a CT coronary angiogram as well? And a CT coronary angiogram is covered by Medicare, calcium score is not. Sorry?
Because his wife asked him to. The GP went right.
That's probably a good answer. This patient had an angiogram done. And you can see here, That's his left circumflex artery, severe disease, LAD, severe disease. An occluded circ, RCA, also severe disease. I think that should work here as well. Here we go. That's his LAD, very bad looking. This patient had a bypass surgery done. So I wouldn't send patient for a calcium score only. Now, what about a negative TSE, treadmill stress echo? Is that an answer?
Just like to qualify that.
Sure.
Most of the time the action score does reflect the atherosclerotic burden, and the evidence suggests that 2% of time in this non-classified.
Absolutely, agree. And I don't want to miss this 2%. That's why I think if I'm sending the patient for a CT scan, I would just send them for CT angiogram, regardless with calcium score or not. Some radiology providers, they charge for calcium score, some not. If they charge for calcium score, I don't bother.
I think calcium score was able to move prior to the ECA.
True.
So I'll be asymptomatic calcium score, I guess. It's got that role. But this guy's got restlessness, so you'd be well within MBS criteria to get a CT, which will give you a lot more information. So if they've got any remote symptoms, typical or atypical,
Yeah.
I agree with CTCA to be way better.
Probably even bypass the CTCA and go for an angiogram if they are symptomatic. But if they decline to have an invasive coronary angiography, then yes, you do a CT coronary angiogram. Agree. Now, what about a negative treadmill stress echocardiography? This is a 61 years old man, recurrent presentation with exertional chest pain, diabetic, hypertensive, high cholesterol. He did 10 minutes on the treadmill. 148 beat per minute, 93%, no inducible wall motion abnormality, but typical angina and some ECG changes. Echo is absolutely fine. What are you going to do? Well, I reported the echo as a negative citrus echo for like an echo criteria, but positive for symptoms and ECG, need an angiogram. Well, this patient had an angiogram. Severe stenosis in the RCA, mid-RCA. This mouse is annoying. Severe disease in the circ. The circ, we did a functional assessment for the left circumflex with a pressure wire that was negative and stented the RCA. That's about 7 years ago, and I'm still seeing this patient on a regular basis. He's absolutely symptoms free. Now, moving to a bit of like more fun. So this is a patient of mine, had a severe disease in the proximal LAD. As you see, it's calcified vessel. So we needed to use a rotablation. And rotational atherectomy is it's a little like a diamond, half smooth surface. We drill into the calcium in the coronary artery to change the calcium in the arteries before we dilate and stent the vessel. So rotational atherectomy. So in this patient, because of the heavy calcified vessels, I used a rotational atherectomy. We managed to get a good result in terms of the rotational atherectomy, and we start stenting. So this is a stent. This is the stent, and after we put a stent and the initial ballooning, we put what we call a non-compliant balloon. So balloon goes into the stent, and we push that calcium even further, just to make the stents more like an opposed to the internal wall of the artery. And I think Matthias will expect what's going to happen next. Here we go. Do you see that? That's basically a perforation. And that perforation occurred behind the stent struts, which initially I was it was actually quite surprised. So it's not beyond the stent struts, it's behind the stent struts. There was probably like a little shelf of calcium, and that's perforated through the coronary artery. And what we can see here, you can see here blood going into the pericardium, So what next? Your heart rate goes up, not the patient's heart rate, your heart rate goes up and probably starts sweat, and then you just scream and run away. No. We had the balloon, the NC, the non-compliant balloon. What I usually do after I pull the non-compliant balloon into the guiding catheter, I test before I pull the balloon all the way out. So we had the balloon sitting around here. So we push the balloon into the stent, within the stent, and inflate the balloon. And by inflating the balloon, you basically stop the leaking. You close the hole, waiting for a covered stent to arrive. And when the covered stent arrives, you pull the balloon out, you put the covered stent in. So here you can see the covered stent. Covered stent, as you all know, stent is a mesh. Covered stent is covered. So basically you put it there, you close the hole, and that's all done. This patient stayed in hospital, unfortunately, for longer than usual. We didn't need to tap the blood from the pericardium. There wasn't really much. But we kept the patient in hospital for 3 days, 4 days. She did have a bit of pain afterwards. Most of the pain is pericardial pain. She survived, she's good, and I'm still seeing her. She's absolutely fine. And you can see here, closed off. Some of those complications, unfortunately, can end badly. A lot of blood in the pericardium, blood pressure drops. You need to tap it, you need to put a needle into the pericardium and drain it. And some of them can end up with a good story. AVR, surgical valve replacement, and TAVR is a transcatheter aortic valve replacement or medical management. So who's with medical management? Show of hands? It's a quiz.
Is the patient symptomatic?
That's a good question. Yep. Anyone else?
Other comorbidities?
So basically what you're saying is can be any of those, yes? 1, 2, or 3. Unless you go for 3, regardless.
Then because of his age and everything like that,
so if the patient is asymptomatic, are you still going for 3?
severe, yeah.
Yeah. Yeah, so severe aortic stenosis, unless the patient is symptomatic, probably don't need to do much about it. Maybe. Again, it's severe aortic stenosis, but if the patient has no symptoms, he's very active, would you operate on him? 83? Yeah, so TAVI isn't a procedure.
The patient was fine, and all of a sudden it felt easy.
Exactly, so that's symptoms.
Yeah, that's it, yeah. So this
Yeah.
he did that.
Yeah.
He
So
had, head injury, that's why because of his age and everything like that.
no, it's not, the age is not, what I'm trying to get to the point here, the point is, even patients with severe aortic stenosis, if they are asymptomatic, just imagine yourself, you have no symptoms whatsoever with severe aortic stenosis, go to theater or whatever technique, TAVI or SAVI, and something happened to you. Not you, not your family will appreciate the work we've done. Because you're asymptomatic, you absolutely have no symptoms whatsoever. So I think symptoms is the main thing, and Radwan mentioned that whether the patient is symptomatic. So the answer is yes, the patient is symptomatic with shortness of breath, recurrent admission with semi-conscious collapse. What would you choose now? 1, 2, or 3? 2?
Between 2 and 3.
2, between 2 and 3. So yes. So the reason why I'm bringing this to discussion, every Friday morning we have the same discussion. Yes, no, medical management, whatever, depend on the patient. So yes, between 2 and 3. Now, how do we choose between 2 and 3?
You guys choose not.
Very good answer. So I would say definitely not for medical management. We should do something about it. So I'll cross the medical management off and I'll say between SAVA and TAVA. Now, what if this patient has coronary artery disease involving left main coronary artery? What would you do now? I'll leave it for Matthias to answer the question. Thank you very much. Of course.
That's a good little introduction to the topic. But first, for those that I haven't met, I'm Matthias. I'm a interventional cardiologist, but I'm mainly focused in structural interventions. And I'm very honoured to have joined the Heartscope family to be able to provide this pretty subspecialised area of cardiology to your patients. Both, I run the program. I did it again. I had a stroke. I run the program at the Austin Hospital, so we've got a great lead-in for all our patients into this very advanced technology. And that wasn't me.
We know that.
For all those people that said that the right answer was surgery, make sure you pay special attention because look, this landscape is changing remarkably, and it's going to come to a point, pretty much where if you're 80 plus aortic stenosis, we're really thinking of percutaneous options for everything. Ali's shown some great cases of elderly patients with coronary disease where we know that we can safely perform something that they're going to go home the next day or two, rather than take 3 months to recover from something more invasive. And surgery's it's great, and it's got a great role. If Ali had triple vessel disease, I'd send him for surgery, right? But when he turns 85, maybe we should treat it a little bit more conservatively with technology that we know that it's very, very good in 5 to 10 years outcomes. So that's exactly where we're at. Would anyone, with the last patient that Ali had, would anyone have sent that patient straight to a surgeon? You get a great echo, PAB reports it, and we've got severe aortic stenosis, and she says, we need some specialist involvement. When you get that, what's the referral pattern? Do you normally send it to a surgeon or a cardiologist or? Yeah, no, look, it's interesting to know the different field. I did a lot of my training in America, and some of the general practitioners sent straight to a surgeon, which is not as common as in here. I find generally that they go to a cardiology involvement first. And to be fair, without being completely biased, and there's no surgeons in the room, obviously, it is the better way to assess these patients because we offer the full spectrum of technologies, from medical therapy to surgery. We send a lot to surgery, but it is important when someone's got severe aortic stenosis that we really give the patient all the possibilities. And we'll work very closely with all these complex cases with the heart team. So they get all worked up, but we all review it as a team, which involves a surgeon rather than one person making a decision, because it's, the data and the technology is changing significantly. Although the IT technology is still a little bit behind.
That patient,
correct,
he was asymptomatic.
Yeah.
Did you follow him up with Like, 8 or 12 months, or what?
Yeah, it's a great question. Firstly, I love to make sure they're asymptomatic, right? And we get all these people that say they're asymptomatic, and then all of a sudden, the wife was parking the car and she comes late into the consult. She goes, oh no, you can't mow the lawn anymore, you can't do these things. So it's important to get history, not only from the patient, but from the family member. In months we've had low risk trial data. So this is why the 72-year-olds guys in America and the US are all getting this, because the data is so supportive. And these have all been published in in the New England Journal, which is the #1 journal. So the editorials all say that it may be the preferred strategy in all those patients that have severe aortic stenosis. So we should definitely think about a minimally invasive route for these patients. There's this guy here, you might know him, but he was someone that was asymptomatic as per his cardiologist, but as soon as the low risk patient was approved, he quickly became symptomatic and got a TAVI valve. He was one of the first of the lower risk patients who have it commercially available. So it is changing, and he was touring within 4 weeks. So it's an amazing technology that I'm sure that your patients will really appreciate. I guess the take-home messages from a TAVI point of view is that we're thinking about a one-time implant because we've got good data that's lasting 8 to 10 years. That's how long we've been looking forward to them. We all do it as part of a team, so it's not, Sonny can't just call me or Ali can't call me and say, hey, Matthias, this guy needs a TAVI. We say, look, he's got AS. We'll see what's the best option after we look at his coronaries and the valve anatomy and all these other factors, and then we'll decide. But it is something that we should consider in all patients. We usually do it to transfemoral under sedation, so they don't have general anaesthetic, and they go home. Our average length of stay is 2 days. Some of the older, more fragile patients, a little bit longer, and some of them go home the next day. The procedure takes about an hour, so it's all about the planning. We all know where the problems are going to be beforehand, and they usually do very, very well.
Matthias, why can't you offer TAVI for everything? What age that a factor? Why not for 70 or 60 or 50?
Yeah, very good question. First of all, the data is there to support, the latest trials are average 72 to 73 years of age. So we've got data that population would really benefit, right? If you've got bicuspid aortic valves or very severe coronary disease or dilated aorta or mitral regurgitation where you may need surgery to fix everything, that's probably a better option. In Australia, the issue is funding. So at the moment, we're really restrained in offering this to the high-risk patients, okay, and a few of the intermediate risk patients. So at the Austin, we've got a general rule that if you're 80 plus, even if you're a great 80-year-old, TAVI should be the default strategy if everything's suitable. If you're 75 and have had a previous stenotomy, or then again TAVI should be the number. You don't want to go in there again. But if you're a great 75 because of MBS criteria, then you probably should have surgery. Even though there is data to support that you get less strokes, less deaths, shorter hospitalisation, less renal failure, less atrial fibrillation, at the risk of having a few more pacemakers.
So the valve itself not an issue?
8 to 10 years we know. So 8 to 10 years, there's no early deterioration. And these valves have been tested in randomised trials. The surgeons, have never done a randomised trial with valves, and they bring new valves in the market that sound good and they've been bench tested to work well, but we've all seen valves that have gone to pieces within 3 years, 4 years, and those valves are now no longer on the market. So I don't think we're going to have this problem with these valves because they've been so tested, because obviously the surgeons didn't want us to encroach on their territory, but they're probably losing this little battle. Yeah.
And do they need to be anticoagulated after that?
Great question. So not if they don't have another indication. If they have PEs or or a atrial fibrillation, they've got an indication, then we get back onto the anticoagulation.
That's TAVI per se.
Per se, no, there's been a trial looking at Xarelto.
They wouldn't be using
No, it's not a good thing. It was a negative trial, so they cut the trial short because it was increased risk of bleeding without any benefit. So, and there's been a recent Apixaban trial which doesn't have any benefit, even though the risk of bleeding is not there. But since if you're not going to benefit the patient, there's no point using it. So we normally just put him on aspirin and clopidogrel, now only for about a month, and then aspirin alone if they don't have another indication.
Put me on your list for the future.
Oh, maybe.
And what happens if your patient lives more than 10 years and the valve stops working the way it should be? What are you going to do?
Yeah, look, it's a great area of research. I've got one patient like that had one of the early valves who now needs a second valve put in. So again, we do a CT analysis and try to work out which one's the best valve. So they had one of the shorter Edwards valves. Now we're going to put a core valve, which is this valve here.
You can put valve in valve.
You can put valve in valve. It's technically feasible. You just got to look at a few technical factors like coronaries and stuff like that. Yeah. So that's any other questions about TAVI?
Is there any sort of femoral anatomy that you can't negotiate, or is it pretty open?
Yeah, look, you need about 5.5 millimeters diameter in the vessels. The fellow, who's not here, but he knows that we push the boundaries all the time. So that's the official IVU, but some of these elderly patients, we don't want to do a subclavian or a direct aortic access. We actually, we can dilate and even put stents on the way out if required in the legs. But theoretically, you need big enough width, and calcium's a bit of a problem. You can usually stretch something, but if it's very calcified and you've got a very small diameter, then you're not going to be able to get through it. So you need intervention.
What about the option of cut down procedure? So you got femoral, but you basically have the vascular team.
Correct. Yeah. Look.
Cut down the
Yeah.
open
Yeah.
and you do the procedure.
Yeah. So we do that. So obviously we need to put we put a couple of stitches externally. When we do it ourselves. If there's a lot of calcium in the femoral artery, you need, like I was saying, you need a surgeon to actually open up that vessel for allow us to put the tube in, and then they close it at the end. And then sometimes they've helped us putting stents in the iliacs if that's required. So, like I said, it's a great team approach because we discuss this case and said, look, this one we're going to need, the vascular surgeon, we may need the cardiothoracic surgeon if we're going to go subclavian or so.
The other option is subclavian that you mentioned, and transapical?
The main type it's gone. Transapical is, if you're going to have transapical, you might as well have surgery. Once upon a time we thought it'd be a good idea just to go make a little hole in the apex and stick a big, 7.5 centimetre rod up there and deploy it, but that's out of favour now. So, good question. I know you're teasing me. It gives me nightmares thinking about doing that sort of stuff. The second great topic I wanted to talk to you about, and this is probably something that everyone's encountered here, is atrial fibrillation. It's a huge issue in the community, and it's only going to get worse as people with multiple cardiovascular comorbidities get older and are at a huge risk of stroke. And this is a left atrial appendage occlusion device that Ali briefly showed, which is a mechanical solution to stroke prevention in patients who can't tolerate an anticoagulant. So look at this is a great, this is another little story. I got back, I got my GP mate who threw me a bone and said, oh Matthias, I've got a patient with palpitations, do you mind seeing them? I said, oh yeah, I'd love to, yeah, that'd be great. And so they've got a few risk factors, but he was a pretty robust guy. And I thought, look, the risk of stroke in him is significant, and I think we need to anticoagulate him. We've done the usual things. You confirm that they've got atrial fibrillation. You do an echocardiogram to make sure you don't have valvular heart disease. So obviously if you've got mitral stenosis, or if you've got a mechanical, any sort of mechanical heart valve, you need to be on warfarin therapy. Otherwise you need to be on Xarelto, right? Do you like that? It's important. Look, everybody is aware of the CHFrEF score, which is probably the only acronym I ever remember in cardiology. But everyone uses it, right? Does anyone use the Haspled score? Really? Respect. Yeah. Look, I put it there just to show off, but I don't often use it. But you have it in the back of your mind about the things that you can potentially modify. And I think that's really, really important. If you've got uncontrolled hypertension or you've got antiplatelet agents, talk to Ali to see which ones you may be able to drop off, because the risks increase exponentially of having bleeds once you're on multiple agents, double therapy and triple therapy. So I think it is really, really important. But I think this guy was pretty fair game that we should anticoagulate. Would anyone not anticoagulate him? 83-year-old, hypertensive, diabetic, functionally pretty good. Everyone would anticoagulate him there? With Xarelto or no? Well, they're different story. Let's not get political. Very good. Look, I think it's very, very important that we do treat these patients aggressively, because the risks of bleeding are much less than the risk of stroke, and the morbidity and the mortality associated with stroke is much higher than the bleeding, potential bleeding complications. So I told him about this. I said, oh, look, you'll be fine, you're going to tolerate this drug, it's great. Then I get a call from the ED. Oh yeah, like this patient that you saw, he can't walk a metre, he's very, very breathless, and as they do in ED, they did a CTPA. And he had a huge pericardial effusion. They thought, oh look, they did a little special test, this is hemorrhagic. I said, oh shit, this is not good. Right? So he was stable. I didn't want to put a needle in there, because obviously you can make things worse. We treated him conservatively, and he gradually self-absorbed, it absorbed. Who would put this patient back on anticoagulation for a stroke? Anyone? Would you change to another NOAC? Warfarin? No?
What's the cause of the pericardial?
Yeah, so he didn't have any virus that we knew about. We scanned him looking for, I thought he was going to have cancer. That was my problem. I said, oh well. And then I went and talked to the radiologist, and they said, oh look, we're pretty confident it's blood. Like, I don't think it's any, we didn't tap it. I wanted to treat it conservatively. But yeah, it wasn't something obviously sinister, but yeah. Oh no, maybe we did tap it. There you go. Nothing came back. It was a Pixagon as well, so there you go.
The company was after it.
Well, that's what I'm saying. Maybe we should put him for Delta first time. We wouldn't have this problem, right?
Maybe his EGFR was 20.
His EGFR was good, actually. But, all very good points. That's a good TGA approval for down to 15. That's game changing. Yeah, good job. So I spent so much time in my first consult with this guy, right? Telling him how bad his stroke's going to be, and now he comes in with life-threatening pericardial effusion, and now he goes, oh look, you told me that a stroke for me would be devastating, how are we going to stop that? Has anyone seen anyone for a left atrial appendage occlusion device, or thought about it potentially? Look, I think it is I think for this patient, it's something that's really worthwhile. I'm not going to talk to you about how common or how deadly atrial fibrillation is. You see this all the time. You're very, very well aware of the statistics. Maybe if you don't spend enough time in the echo lab, you know that you've got this little appendage in the left atrium that we're still trying to work out exactly what its function is. But its main function is really to be a nidus for thrombus. So when you lose your atrial kick, you have a lot more swirling around, so you've got incoordination in the atria, and you can theoretically develop thrombus in this appendage because you're not getting blood that's circulating in and out as efficiently. And this is where 90 to 95% of thrombus form in atrial fibrillation if you don't have mitral stenosis or a mechanical valve. So, Yeah, very bad. So look, in the international guidelines, oh, that's good. I think we're all clear with the international guidelines. You know, we've moved into the CHAS-BA era, so we've got rid of females. #Me Too movement is caught on to atrial fibrillation. So we don't discriminate anymore with females, which is good. If we have a CHAS-BA of 0, does anyone put him on aspirin? No? That's great, you guys are doing a great job. Because there's no data, even though there is still the similar risk of bleeding compared to NOACs. I think if you're CHAS-BA or 1, you should think about it. And I've got an old school cardiologist who tells me everyone's got low CHAS-BA till they have a stroke. So he's pretty aggressive with his anticoagulation. I still talk to the patient because it's a hard sell if you've got 30, 40 years of the medication. And obviously if you've got a CHAS-BA 2 or plus, you should anticoagulate him. The benefit is worthwhile. But in those that you can't anticoagulate for whatever reason, or they have major bleed, I think it's important to think about this potential mechanical solution. We all know that there's great randomised trial data with the NOACs. I'm not going to talk about that. And we talked about Rocket AF earlier today, which was a game-changing study. What we do know is when surgeons take out the left atrial appendage for whatever reason in people with atrial fibrillation, right, their risk of having systemic emboli down the track is much lower. So we really do think that their left atrial appendage is a source of thrombus formation. And then that's what we thought, that it's always clever to try to outdo the surgeons and do something minimally invasive. So this is something that we do from the femoral vein. So, you know, it's a venous procedure. We cross the septum this is under general anaesthetic with transesophageal echo guidance. And then we insert this parachute-like material into the appendage to make sure that nothing can come out of the left atrial appendage. And this has been studied and it's non-inferior to anticoagulation with warfarin therapy. That's when the first trials came out in preventing strokes, ischemic strokes, but also decreases significantly the hemorrhagic strokes and the bleeding complications because these patients don't have to be on anticoagulation. And right now, where are we using this? We're using this with elevated CHAS-BA score and have an appropriate reason to seek a non-alternative cause. And that's usually bleeding. We get a lot of referrals from haematologists for blood dyscrasias where they're uncomfortable about anticoagulating long term. We get obviously a lot from the neurology, from amyloid angiopathy, and obviously bleeding from any part of the body, from GI or GU. We've had a few from GI bleeding. We had a couple of retinal bleeds as well. So these are the kind of patients where you would be reluctant to restart the anticoagulation. Look, I won't bore you on the data. So it's we've got the Watchman device on one side and the 2 randomised controlled trial meta-analysis, and this was what the FDA wanted to see before they approved this device, is that you're really, you know, non-inferior to warfarin in preventing all-cause strokes, and then you're getting less hemorrhagic strokes. And the thought is that you get less hemorrhagic strokes, you get less massively disabling strokes, and that is potentially the reason why you get less mortality in this patient data. But it wasn't powered looking at mortality, they were looking at just strokes. So it's thought-provoking, but very positive, which led to its approval. Has anyone got any questions about left atrial appendage? Yes?
This one sounds like to me is a plug.
Correct.
Yeah?
Correct.
So behind that plug, is there a big clot?
Well, look, it does, you get clot behind it, but the key is that you are completely occluding it. Yeah. So you size it, and before you let it go, you're making sure that there's no little leaks around the device. And within 3 months, you get endothelialization, so it becomes part of the atrial wall. And
is there a risk of dislodgement?
There is a risk of dislodgement. Would I've never seen one. Hopefully, I'm never involved in one. But echo sizing is so important. So you actually give it a firm tug before you let it go to make sure it's not going to go anywhere, and you oversize it to the appendage. So, but there is a risk. Yeah.
So when we talk about risk of dislodgement, you mean an immediate risk or long-term?
Look, it's usually immediate. Yeah. Look, once it gets endothelialized, it's not going to go anywhere. But if you don't do it properly, if you're not comfortable or you think it's moving when you're tugging it, you take it out, you get a bigger size, or you can stop depending on how you feel. But
I'm just thinking about plumbing job I've done last week.
Correct. Yeah. Look, I hope that your pipes are a little bit more forgiving than the atrial appendage, which is very, very thin. So the common risk, which I tell my patient, is to have a pericardial effusion. And I quote about a 1% risk. We haven't had one, but it is that risk because the appendage is actually very thin. I've had the pleasure of playing with some pig appendages, facial appendages. And if you put your finger in there, it's actually very, very thin structure. So the left atrium it's not thick wall, but the left atrial appendage in particular is very thin. So that is a small risk that you're taking up front for lifelong stroke prevention.
You still need to use antiplatelets initially for the first 6 months?
Yeah, look, it's controversial. We use 45 days usually of some sort of anticoagulation, depending on the patient.
Antiplatelets or
Anticoagulation. So if they've got a complete contraindication, like a amyloid angiopathy, intracranial hemorrhage, and the neurologist says no, then that's fine. But if they've got a GI bleed, and if it recurs, it can be treated, then we usually, in the first 45 days, while the device in the endothelializes, we like to have some sort of anticoagulant on board. But it's very patient-based, and the data around that is not robust. Any other questions? So this is not overtaking any NOACs. I think that's important. But this is for those people that cannot tolerate it. No, but it is important. Some people say, why don't we put this on everybody? And the data is not as strong as the other blood thinning medication. I'm very scared of this computer because of that. Oh no, yeah. Look, it's that's what it looks like when it opens out. So it's a small device, fits through a 14 French, which is about 4 millimeters, which is smaller than what we use in the TAVI valve. We put it in the vein, and then we feed it all the way up to the heart. These patients go home the next day, so there's usually not a major issue. The bleeding risk is much lower because you're going through the vein. You puncture under direct vision from the echo guys who tell you exactly where to put that needle as you cross the septum. You don't go through the PFO. And once you're in there, you're obviously doing everything image guided. You've got the angiogram, the suite to guide you fluoroscopically, and then you've got the echo guys to let you know what you do. That's a pulmonary vein. AF guys love hanging out there and doing some burning to make sure that AF doesn't come back. But that's our safeguard. So we're not going to perforate anything, and then we gradually come down to the appendage, which has many different shapes, as you can see here: chicken wing, broccoli, windsock. But you can use your imagination. You get all kinds of weird things, and then you put this little catheter there just for safety because it's nice and soft. Then you get rid of the pigtail, which you can see in there, and then you get the device to come across in due time. But it is quite nifty. So that we inject there just to see exactly where we're at, and we can measure where we're going to land. And here comes the device, and then you just unplug it, like you said. You position it so the key is not to push forward, it's just to push everything back, and the umbrella opens up, and where the plug opens up. It's a gentle tug. I'm a little bit more aggressive, so we don't get embolisation. All right, and then you do injections to make sure there's no leak, so you can't get clots around. So again, look, this is another great technology that's available for some of those patients, and we don't make that decision individually. We talk in a big meeting about that. Look, I won't take too much more of your time, but you've been a great staff. But as you can see, I love putting devices in people. PFO closures is very much established now, but in any patient that's had a stroke, especially young patients with no other cardiovascular risk factors, I think that they should all be screened for a patent foramen ovale. And this is the patient that was treated at Royal Melbourne actually, and then went back to the country, and then it was lost to follow-up, and then the GP very rightly said, oh, why did this patient actually have a stroke? You know, he was treated, but is fit and well, has no risk factors, didn't use any drugs, and you know, his echo was normal at baseline, but we ended up having a PFO and closing that for him. In the interest of time, I won't go through it, but look, it's 1 in 3 strokes we don't find a cause for, so they're cryptogenic, and these are the ones we particularly need to have a low threshold for looking for atrial fibrillation and a patent foramen ovale. So prolonged monitoring for atrial fibrillation is the key, and especially if you're very, very young, you need to make sure that they don't have a PFO. And in those that have a cryptogenic stroke, about half of them is related to a PFO that we normally close. Again, look at the other 2 procedures that I showed you are pretty high risk. This is as low risk as they come, putting a PFO closure, because you just feed a very small wire through that hole, and then you get 2 discs that sit on either side of the atrial septum, and you bring that together, and then there's no further flow through that tunnel that we're all born with, and it remains open in about 1 in 4 of us. So look, we won't talk about the cryptogenic stroke workup, but the key is to think about emboli in your setting. When they come to you, they would have done, proven that they've had an MRI. They usually look at the carotids at the same time with the CT or the MRI. But sometimes, because of bed pressures, they get sent home on aspirin and statin. But if they don't follow through, it is important to think about the actual cause in these patients. There's great data now. 6-7 years ago, we didn't have this data. Now there's 4 randomized trials looking at PFO versus medical therapy alone, and there's a significant relative risk reduction. So it's standard of care now. And I don't have a video, but this is what we talked about. You just put a little catheter across. You get one of the discs on the left atrium. You bring it back so it's right against the wall, and then you pull out the second disc. And again, give it a nice tug so it doesn't go anywhere, and then you deploy it. So again, this is a one-time implant. This is, people go home the same day. Here we do it under general anaesthetic just for patient comfort, but we can do it minimally sedated, but it's a bit more uncomfortable having a transesophageal echo down your throat. And they don't stay overnight anymore because of bed pressures. So we have had to become a little bit more ingenious in doing them early and then getting home towards the end of the day. So any questions?
I have a question.
Yeah.
I had a patient 10 years ago who was doing welcoming and propulsion. And a patient presented, he was 35 years of age, presented with atrial fibrillation. We sent him, and a stroke.
Yeah.
So he had a stroke. With propulsion, we didn't have that sort of facility to do anything. So we sent him down to Indigo, I think, back then.
Yeah.
Had an MRI of his brain clearly showing a stroke. Had an echocardiography showing a small ASD/PFO. An ECG showing recurrent episodes of AF, atrial fibrillation, but also has a wall Parkinson White syndrome, so delta wave, clearly there's a delta wave.
Yeah.
I sent him to David O'Donnell to sort him out, so I know what the answer is. What do you think? What are you going to do?
Well, you need to treat the wall Parkinson white. I think that's the most important thing.
Would you close the DFR or would you just wait?
At 35, that's the big issue. I would look at the. If he was an older patient, I would just tell him to be on anticoagulation. At 35, I think closing the PFR, discussing dropping anticoagulation, depending the left atrial function and there's treatment.
Back then we did the same thing 10 years ago. We took the wall and closed the DFR. I think, as you said, 35 years of age, there's a high chance that we'll have a stroke again, especially that's probably because it was an aneurysmal septum.
Yeah.
So we end up doing the wall Parkinson
If you're 60, you had diabetes, hypertension, you know, they're going to be on anticoagulation forever, so they should. There's no obvious.
Some of the AF, I have a patient was AF 55 at AF.
Yeah.
And it was, we had cardio version.
Yeah.
So it was, and then after I think 3 months of that problem, and then aspirin. 5 days again AF. This time was normal with every other one.
Yeah.
And 3 months of the problem, and then he's fine now. Just aspirin in, take a lot of his care. Remember his heart racing, he thinks that he's going to AF.
Yeah.
Is there anything we have to do, like that exercises? Is there anything? Aspirin, basically the role of aspirin with preventing stroke.
There is no role. You're in luck because you've got Dr. Prabhu, who's an expert EP guy, right here, Sam Deep, and he's done his PhD in this area. So maybe, Sonny, maybe you can have a little answer.
55, he sounds like his best score is live move. Carrying super AF would be a really good candidate for ablation for a long-term cure of his AF.
Generally, only lost it, and then after 3 months, there's nothing.
Yeah, the natural history of AF, I mean, there's a few things. One is, if he's got risk factors, you know, such as weight, alcohol, hypertension, diabetes, so on, we know controlling those can certainly reduce the risk of recurrence. But the natural history of AF is once you've had an episode of AF, the risk of, unless it's clearly reversible cause like thyroid dysfunction or infection or something like that, the risk of having AF coming back, so AF begets AF is a common thing that we see.
Family history is a factor. His father had AF. Is family history a factor or not sure?
Not in a classic genetic sense. We do see, occasionally we do see some families where AF does seem to run in families. They don't have any other risk factors. But we do, it's not really something that's, it's more just sporadic than a clear genetic or inherited condition. But generally, for most patients we use ablation as when antiarrhythmics fail, or when as an alternative to antiarrhythmics, and particularly young patients who don't really want to be on long-term antiarrhythmics. So quite often I would change someone to what we call a pill-in-the-pocket approach. They just take an antiarrhythmic at the time they have the symptoms. And if they get recurrent symptoms, they need the pill-in-the-pocket regularly. Usually offer them either regular antiarrhythmic therapy or catheter ablation, you know, if they're otherwise ineffective.
Just a different question.
Yeah.
What do you think the future landscape of intervention will be if the TAVI uptake increases? Intervention post-TAVI?
Coronary interventions. Yeah, look, it's a great area of debate. How you're going to get back into the coronaries. And there's 2 major valves, and both have issues because the frame extends above the coronary ostia. So you're going to be able to you're going to have to manipulate around those frames to get in. It's very doable, but you might have to use some advanced techniques, with guidelines, for extra support, and different guides. But the issue is going to be in 10 years' time when we have to put 2 or 3 valves in there, and getting, if they've got significant coronary disease, that's going to be really tricky. So,
My patient, 83 years old with severe left main disease and not fit for SAVA, and we ended up putting a TAVI in there. How are we going to fix this left main?
Look, that should be fixed beforehand,
Yeah.
but then we should go back in. And again, looking at the CT, you need to be able to predict which patient, where you're going to deploy the valve and which valve you're going to deploy to make it easier for you to go back in.
Well, we can fix the left main, that stent in the left main before the TAVI.
Yeah. So I think they need to be revascularized before. Like proximal disease, obviously left main is proximal to gets. That should be done beforehand. Yeah, that's all the guidelines. I think we've done a few of those.
Yeah.
The Austin. So.
With the appendage occlusion devices, occasionally these patients with sort of chronic organised thrombus in their appendage. Is that a contraindication, or is that patients you can do those?
Yeah, no, look, it's so all these patients have stasis, so you see smoke floating around, but you have to rule out a thrombus because, as you saw in the video, you're going to put a pigtail in there and a catheter. And if you go in for an elective, because this is an elective procedure, this is not a life-saving procedure like the TAVI, for example, and you cause a stroke, that's a terrible outcome. So we've had a few where it looks dodgy, we put some definitive, and if it looks like it's a definite thrombus, abort. So yeah, we don't put any catheters inside till the echo guys are happy that we have no thrombus. Any questions, guys? You've got a big fabulous audience. I hope no one can pick number 2 again. I think that's the theme of the night. But look, thank you for having me, and it's been a pleasure.
Thanks, Matthias. That was a great introduction and a very exciting area of cardiology that I'm sure a lot of the doctors haven't seen, so thank you. Very quickly, we just want to wrap up the evening. A few thank yous to the representative from Bayer, and thank you for your sponsorship this evening. Jason, thank you for all your assistance. And I do want to also mention that we have a new site in Coolaroo that Dr. Ali is consulting at. So for the doctors around the north, if you're not aware, Coolaroo on Pascoe Road has also opened for your patients' convenience. So if Thomastown's a bit long waiting times, send them across to Dr. Ali in Coolaroo. Also, we just wanted to thank you again for coming along tonight. It did go a little bit over time, apologies for that, but hopefully it was quite useful information and a lot of insight into where the cardiology space is moving into. So again, safe trip home. Don't forget to validate your parking tickets and grab your goodies bag on your way out. And so on behalf of Heartscope, thanks again.